Thank you so much. It's a pleasure and honor to talk to you. Thank you so much. It's a pleasure and honor to talk to you this afternoon. I really thank the organizers for giving me the opportunity to take part in this great event. It would have been much nicer if I was in person in Semiramis Hotel in Cairo, or visiting my colleagues and friends in Alexandria or Asyut. This being said, let's take the opportunity to discuss pouch-related disorders. I'm pleased to have experts in the field with us this afternoon in this session. So these are my disclosures. Let me start with a case from the literature. This is a 63-year-old gentleman with long-standing history of ulcerative colitis, required proctocolectomy and IPAA, presented to the clinic almost a year after his surgery with symptoms of abdominal pain, diarrhea, and high fecal lactoferrin. He had lower GI endoscopy done, and this is an image of his pouchoscopy evaluation. So these are the kind of cases we deal with after pouch surgery. I'll get back to the case later on in my presentation. Over the next 15 minutes or so, I hope to go over some practical, surgical, and physiological aspects that are of relevance to practicing gastroenterologists. We'll talk about Pauchitis, the most common inflammatory complication related to pouch surgery. I'll give some tips about endoscopic evaluation of the pouch, and then we'll talk about Cuffitis, and finally, the unfortunate outcome of pouch failure. Generally speaking, taking a patient from having colon and rectum into having an IPAA goes through two steps of surgery: proctocolectomy, followed by ileostomy and creation of an ileal pouch anal anastomosis, and then finally the closure of the ileostomy and restoration of the continuity of the bowel. In most centers, this is done in actually three-step fashion, where the proctocolectomy is done first, followed by the creation of the pouch, and the third step is closure of the stoma and restoration of continuity of the bowel. The IPAA resumes the patient's good quality of life a year after having surgery. Patients usually go through an adaptation phase with increased frequency of their bowel movement. So both the patient and the healthcare provider need to be patient. Don't expect miracles in the first 6 to 12 months. The frequency of bowel movement can be up to 4 to 8 during the day and 1 to 2 bowel movements during the night. Unfortunately, some patients may experience fecal leakage. Up to 4% of them do. That's during the day. And almost a third of them will require antidiarrheal agent to be used on a regular basis. There are important impacts of having a pouch on the patient's sexual life and fertility. In men, it can lead to erectile dysfunction in a very small percentage, 1 to 2%, and a failure of ejaculation, 3 to 4%. In women, it leads to lower fertility rate, particularly if it's done in an open fashion rather than a laparoscopic fashion, and a fourfold decrease or reduction in involuntary fertility rates. In patients who had IPAA, you may want to consider C-section for their delivery to avoid injuring the anal sphincter during vaginal delivery. If you think broadly about the potential complications related to pouch creation, it can be surgical related with anastomotic leaks, particularly earlier on after surgery, strictures, having presacral sinus, or pouch vaginal fistula. The medical complications include Pauchitis, de novo Crohn's disease, and we'll talk about it later on, Cuffitis, irritable pouch syndrome, and malignancy in the anal transition zone or rectum. So Pauchitis patients can present with frequent bowel movements, abdominal pain. Remember that patients who present with symptoms suggestive of Pauchitis, up to a quarter of them will have no evidence of inflammation on endoscopic or histological evaluation. And these patients have what we call irritable pouch syndrome, a form of functional GI disorders. Pauchitis is more common if the patient has underlying primary sclerosing cholangitis with ulcerative colitis. One may be able to prevent Pauchitis from happening if you use a BSL-3, a probiotic, for 12 months, usually 2 packets per day. This has been shown in randomized controlled trials to reduce the chances and risks of having Pauchitis. Classifying Pauchitis can depend on the number of episodes or duration of an episode of Pauchitis. Less than 4 weeks, it's an acute event. More than 4 weeks, it's chronic. And we can label it as relapsing if we have more than 3 episodes a year. And then you can look at it from the perspective of dependence or responsiveness to antibiotics, to either antibiotic responsive, antibiotic dependent, or antibiotic refractory. The cause can be idiopathic or can be secondary to infections, medications like NSAIDs, or other potential causes. In most patients, it happens within the first 12 months after surgery, 40% of patients within 12 months. Intermittent Pauchitis is less common, only 19 patients will have it. In a minority of patients, 5%, they will have chronic Pauchitis. The first line of treatment in cases of acute Pauchitis is antibiotics course. We usually recommend a 2 to 4 weeks course of ciprofloxacin or metronidazole as a first-line agent. And if this fails, our second-line agent are either rifaximin or amoxicillin clavulanic acid. In cases of relapsing Pauchitis, with acute Pauchitis, luckily, the response to antibiotics is up to 80 to 95% of patients. In cases of relapsing Pauchitis, one would have to rule out other causes like CMV, C. diff, and the use of NSAIDs, something that we usually also check for even in the first presentation. Repeat the antibiotics course, and if the patient has chronic antibiotic-dependent Pauchitis with more than 3 episodes per year, consider putting them on long-term rifaximin or VSL number 3. So once the diagnosis is made, treat with antibiotics, metronidazole or ciprofloxacin. The first relapse, another course of antibiotics. The patient has chronic antibiotic-dependent Pauchitis with multiple relapses. They may need chronic antibiotic use. And if there is a loss of efficacy to the initial regimen, consider cycling antibiotics. If the patient is refractory to antibiotic, consider immunosuppressive therapy with 5-ASA compounds, budesonide or anti-TNF. And more recently, evidence suggests useful use of vedolizumab or ustekinumab. When you assess the pouch, preparation of patient is important to give you a full, appropriate look at the mucosa. The patient will require preparation with 2 fleet enemas or half bowel preparation that you would give for a patient requiring colonoscopy. You need to use a gastroscope. This is much easier to retroflex in the pouch.
Professor Turki.
Yes.
Sorry for interruption, but we have network error and we lose the connection 5 minutes ago.
Okay, so where did you lose me? So I can.
After the 3 or 4 slides.
Okay. So you may have lost me with the Pauchitis. I'll get back to it if we have time at the end of the
presentation. Can we repeat it, please? Yes, from disease.
Yes. So when evaluating the pouch with endoscopy, you need to give the patient 2 fleet enemas or half bowel preparation that you would give for a colonoscopy. Use a gastroscope. It's easier to retroflex in the pouch if with a gastroscope. Remember that biopsies are not indicated unless you're looking for surveillance reasons or there is active inflammation, because if you take biopsies, it may show inflammation even if the mucosa appeared normal in endoscopy, and that would have impact the clinical picture and puzzle both the patient and the healthcare provider. This is the basic anatomy of the pouch. You have the afferent limb, the pouch inlet, and then you have the afferent limb and the tip of the J pouch, and at the end you have the rectal cuff and the anal transition zone. If you need to take biopsies, take 2 to 4 samples from the afferent limb, 10 centimeter above the pouch inlet. Take biopsies also from the cuff, the rectal cuff, or the anal transition zone if you're looking for dysplasia. And try to retroflex if there is no active inflammation. It will identify distal pouchitis, perianal fistula, or pouch vaginal fistulas. Evaluation of the stoma closure site is an important part of evaluating a patient with a pouch. This is usually 50 centimeters from the anal verge. Having ulcerations and strictures at that point suggest Crohn's disease rather than pouchitis or ileal disease. 1 year after surgery, you start surveillance and you repeat it at 3 to 5 years point, depending on the patient underlying risk of having dysplasia. In the endoscopy report, it's recommended that you have you comment on the distensibility of the pouch body, extent and severity of inflammation, whether you were able to perform a pre-pouch ileal intubation, and the reasons for failure, if that was the case, including strictures or other reasons. So these are the important landmarks. Ileostomy closure site, you can see in the figure a normal closure site with no evidence of inflammation or stricture. The afferent limb, as I indicated in the figure, and the pouch inlet, the classic owl's eye appearance, and it appears normal in this particular case. The tip of the J pouch, you can see a dead end here. And the reason why you need to examine the pre-pouch ileum is that inflammation in the area is a distinct entity, pre-pouch ileitis, usually associated with pouchitis. However, it can happen in isolation. In up to 30% of patients, it is difficult to make a distinction between this entity and Crohn's disease. However, consider Crohn's disease if you have skip lesions, if the lesions are more than 50 centimeters proximal to the pouch, or if the inflammation is restricted to the ileum and the pouch is intact. And obviously, if you have granulomas, non-caseating granulomas on biopsies of the inflamed mucosa. This is a rectal cuff, an important area to examine. It usually extends 2 to 2.5 centimeters in length. Depending on the surgeon performing the procedure, they may just leave an anal transition zone as seen here on the right-hand side. The pouch-related cancers usually happen in this area, the rectal cuff or the ATZ. This is an appearance of normal rectal cuff in a patient who had an IPAA. Again, this is what you would expect with a normal anal transition zone or rectal cuff. And this is a patient with inflammation of the cuff, so-called cuffitis. And it tends to be diffuse circumferential inflammation, happens in almost 1/10 of patients with IPAA. Usually patients have diarrhea, tenesmus, urgency, similar to what you would expect with pouchitis. However, rectal bleeding points more towards cuffitis than pouchitis, and antibiotics are ineffective. That's why it's important to make the distinction between cuffitis and pouchitis, because antibiotics are usually not effective, and the treatment of cuffitis tends to be in line with what you would use for patients with ulcerative proctitis. That's topical 5-ASA, followed by immunosuppressive therapy, things like budesonide and anti-TNF agents. This is a patient with underlying primary sclerosing cholangitis, undergoing chromoendoscopy with evaluation of the cuff. So the surveillance protocol after surgery, if there are risks of dysplasia or carcinoma at the colectomy, at the point of colectomy, then you do annual flexible pouchoscopy. If there wasn't any, do pouchoscopy at 1 year after surgery, and then based on the type of mucosa, you decide to repeat the pouchoscopy after 10 years, or if there is underlying risk, 3 years, especially in patients who are prone to have malignancy and dysplasia. Other important potential complications include presacral sinus, usually associated with leaks in the pelvis post-operatively. This is a lower GI contrast study. Pouch vaginal fistula in female patients. And the case I presented earlier on, patient had Crohn's disease-like condition of the pouch, can happen in 10% of patients. You can see on the left-hand side the inflamed ileum related to Crohn's disease. On the right-hand side, there's a normal proximal ileal loop. And also ischemic pouchitis can have this half and half appearance. So it's the de novo condition, happens after the patient undergoes surgery. It can cause pouch failure in 1/3 of patients. And it can present with strictures, as shown in this case, stricture at the pouch body and stricture at the inlet of the pouch. The most serious complication for the pouch is failure of the pouch. It can happen in 15% of patients after 20 years. Most common causes include pelvic sepsis, poor function of the pouch, and pouchitis. Failure results in permanent ileostomy, and it can happen either early, usually related to surgical complications, or late, and it is the most commonly feared complication of the pouch. This is a suggested diagram to manage patients with chronic pouchitis. I think I have 3 minutes, or 3 more minutes, shall I go back to my acute pouchitis slides, if that's okay with you? So as I was mentioning, pouchitis can happen in 25% of patients, may have symptoms of pouchitis. However, they may not have objective evidence of inflammation. That's a functional disease. The primary prophylaxis method of choice is VSL number 3. And then we divide the pouchitis based on the time frame of the disease, response to antibiotics, and the underlying cause. The first line of treatment is antibiotics with ciprofloxacin or metronidazole, and the second line of treatment is rifaximin or amoxicillin clavulanic acid. If the patient relapses, then you need to rule out other causes, including CMV and C. diff. Repeat the antibiotics course, and in cases where a chronic antibiotic-dependent pouchitis, consider long-term rifaximin or VSL number 3. So in conclusion, ileal pouch anal anastomosis, patients should expect 4 to 8 bowel movements per day, 1 to 2 during the night. Acute pouchitis, first line of treatment is ciprofloxacin or metronidazole. And pouchoscopy, when you perform it, use a gastroscope. It's easier to retroflex using it. De novo Crohn's disease happens in 10% of patients, and it's managed in line with how would you manage Crohn's disease. Thank you so much for your attention.
Thank you, Dr. Turki, for this nice presentation. I'm sorry for network error. Anyone from the floor have a question?
بعد اذنك يا دكتور صبري كنت انا have a comment.
دكتور احمد بيه ازي حضرتك؟
ازي اخبارك عامل ايه؟
استاذنا الكبير.
I would like to thank Dr. Turki for his elegant talk. I'm a colorectal surgeon. I'm very much concerned about the ileal pouch anal anastomosis. We should emphasize on the technical aspects of doing pouch as a background of these complications. Most of these complications, large number of cases of Pauchitis are due to technical problems. We should maintain the blood supply of the pouch. Sometimes ischemia induces a picture like that of Pauchitis. The size of the pouch, the volume of the pouch, the type of the pouch, the type of the pouch anal anastomosis, because we have J pouch, S pouch, and W pouch. As the pouch increases in the volume, the incidence of the Pauchitis increases. So you have to maintain the optimum volume of the pouch to maintain the proper function of the pouch. Moreover, leakage or pelvic sepsis or stenosis also simulate cases of Pauchitis. All of these conditions are related to technical failures, surgical technical problems. So the problem of the pouch usually starts in the OR. We should emphasize on the teaching the young surgeons how to perform such perfect pouch to avoid troubles for the gastroenterologist. Thank you very much.
شكرا دكتور. شكرا.
Thank you, Dr. Ahmed, for this nice talk. Anyone from the floor? Dr. Ahmed, تفضل. Dr. Ahmed Zaid, تفضل.
Thank you for a nice presentation. I would like to ask about the pathogenesis of Bauschitis. It is hypothesized that it can be immune mediated, and some cases has been correlated with the increased p-ANCA, IgG4, and PSC. How can you explain the immune mediated theory in Bauschitis, especially after the removal of the diseased colon?
That's a very good question, Dr. Ahmed. I'm afraid I don't have a clear answer. Definitely immune-mediated diseases in cases of chronic Pauchitis. However, I think the major pathogen here is actually dysbiosis in acute Pauchitis. Therefore, we have good response to antibiotics. But I totally agree with you in cases of chronic Pauchitis and relapsing Pauchitis, probably underlying immune-mediated diseases. The exact nature of how these factors play a role, I'm afraid I don't have a clear understanding of it.